Assalamualaikum and hi. Today we are presenting our group project which is heart population and cardiovascular risk. So first, I'm going to introduce my team. First, I'm Zara Ariana. My other members is Izati Akila, Nik Dini Adrana, and Amira Atika. I'm going to start with the objective 1. So we have 3 objectives. First, to analyze respondent and profiling based on demographic characteristics. The second one is to analyze the relationship between lifestyle habit. And the third one and the last one is to analyze early risk identification. So we move to our next session, which is target audience. We have 3 target audience. First is health professional. Why? To insight into obesity-related risk factor associated with cardiovascular disease. The second one is public health authorities and policymakers, because we need to raise awareness, support preventing effort, and help make informed policy decision to reduce obesity and cardiovascular disease risk in the population. So the last one is the public or civilian. Because why? Because we need to raise awareness about how daily life, how daily habit and medical history can affect long-term cardiovascular health.
Okay, now we're going to talk about chart. The first chart shows the number of respondents that have high cardiovascular by BMI category, age group and gender. Looking at young adults, it shows the highest count for obese to have high cardiovascular for almost 600 people in both gender. Next, the youth age BMI category have at least 200 people that involve in high CVD risk. In conclusion, this chart says that obese category in each age group always have people who have high CVD risk. Okay, now let's look at chart 2. This combo chart shows the count of respondents of high CVD risk according to BMI category, medical condition and family history overweight. For the people who have family history overweight, it shows in yes. It seems that for obese category have high risk in diabetes and hypertension, which is over 400 people. While in no, who does not have family overweight, it showed that there is low people who have high risk in diabetes and hypertension, especially for obese category, which is almost no one. With this, we could see that family history or genetic does affect in BMI category. The people who have family history, mostly the one who have high risk in diabetes and hypertension.
Let's move to chart 3. This chart shows the lifestyle habit of the respondent by travel method, dividing into age group and also BMI category. As we can see, there are 3 types of travel methods, which is public transport, vehicles such as car and motorcycle, and also by walking. Public transport and vehicles are used more often than walking. For middle age and young adults, vehicle use is high, especially among people who are underweight or normal weight. Public transport is also common, mostly for young adults, where it reached one of the highest points on the chart. For youth, public transport is used the most, especially for those who are obese and overweight are above 300 respondents. Vehicle use is lower comparison and walking remains the least popular travel method. Overall, the chart shows the younger people rely more on public transport, while vehicles are more common among the adults. Next, chart 4. This area chart shows that lifestyle habit of alcohol consumption by gender and also high CVD risk sort in frequently, no, and sometimes for alcohol consumption divided by gender. For female, most respondents drink alcohol sometimes, which more than 500 respondents, but fewer report not drinking and very few drink frequently. In all drinking categories, the number of female with a high diabetes risk is higher than those with a low risk, while for male, the total number of respondents is higher than for female. Most male show no alcohol consumption, followed by those who drink sometimes, with frequently drinking being the least common. Similar to females, high diabetes risk is more common than low risk across all alcohol consumption levels. In conclusion, the chart suggests that alcohol consumption alone does not clearly determine diabetes risk, and other lifestyle or health factors likely play a more important role for both male and female.
My name is Siti Amiratika and I'm going to explain chart number 5. As we observe the data, this combo chart shows lifestyle habit of respondent in vegetable intake and high calorie intakes, sort by often, rarely, and sometimes. For high calories food and yes or no for vegetable intake, and divided into BMI category. The underweight group has the smallest number overall. The highest count is only about 120 respondents, mainly among those who sometimes eat high calories food and vegetable intake. For the obese category, respondent counts peak when high calorie food intake is reported as often or sometimes, particularly among those who do consume vegetable. Among individuals with a normal, the category highest number of respondents is observed in the group that often consume high calories food while also reporting vegetable intake. In conclusion, vegetable intake for yes are higher among respondents who often or sometimes consume high calorie food, while rarely consume high calorie food correspond to lower counts in general. Next, I'm going to talk about chart number 6. This chart shows the differences between respondents who have high or low CVD risk are either in good or bad medical condition, such as diabetes, hypertension, and none. As we can observe, people who have high CVD risk are mostly have bad medical condition, which is diabetes and hypertension. In obese category, there are more than 800 respondents that have diabetes and hypertension. For the one who is in low risk, they do not have any problem in medical condition. In a nutshell, the people who have high CVD risk mostly have problem with their medical condition.
End of our graph explanation. So we move to our conclusion. So I'm going to start with the conclusion for objective 1. So in objective 1, we can see that the data confirm that BMI category, age and gender are key determinants in CVD risk profiling. The majority of respondents are overweight or obese with a concerning hypertensive prevalence. The highest risk group is middle-aged male in the overweight, highlighting the need for targeted preventing and early interventing in public health strategies.
Next is conclusion for objective 2. In conclusion, there is a strong interconnected relationship between key lifestyle habits and BMI categories. For example, the physical inactivity in travel choices aligns with poor dietary patterns such as high-calorie foods and low vegetables. Other than that, higher alcohol consumption, especially in males. These habits cluster notably in obese individuals, particularly among males and middle-aged groups. This forming a clear lifestyle risk profile for CVD and related metabolic condition. Last but not least, we can reduce CVD risk with address these lifestyle habits together, such as promoting active transport, balanced nutrition and moderated alcohol use, especially for high BMI and male populations.
Next, conclusion for objective 3. In conclusion, BMI categories serve as a practical and effective early risk identification marker for CVD-related conditions such as hypertension and also diabetes. Therefore, the results indicated that obese and overweight individuals represent the highest risk group and should be the primary target for early intervention, regularly monitoring, and also lifestyle modification program compared to normal and underweight groups. Why? Because these two groups are lower in risk. They still require periodic screening to catch early onset condition linked to non-weight related factors. To conclude, these support the use of BMI-based profiling in public health strategies for early detection and prevention of cardiovascular diseases.
Next, overall dashboard conclusion. In conclusion, this dashboard clearly demonstrates that CVD risk in this population is multidimensional, influenced by demographic factors, lifestyle choices, and weight status. This high CVD risk rate calls for urgent, coordinate action, combining individual behavior change, healthcare system intervention, and community support programs. Success or not will depend on sustained, targeted efforts addressing the causes identification across all three objectives. Thank you.